So we were discussing antidiuretic hormone that is secreted by the posterior lobe of pituitary gland. The function of antidiuretic hormone is that, remember that antidiuretic hormone or ADH is a water-loving hormone. It causes a reabsorption of water from the urine in the kidney tubules. So basically, the function of antidiuretic hormone is making the urine concentrated because it reabsorbs the water from the urine as it is a water loving hormone. So that's why the main function of antidiuretic hormone is to make the urine concentrated. So what will happen if there is excessive secretion of antidiuretic hormone? If there is excessive secretion antidiuretic hormone, it is known as syndrome of inappropriate antidiuretic hormone or SIADH. SIADH can occur in secondary to small cell lung cancer, secrete ADH. So small cell lung cancer can be associated with syndrome of inappropriate antidiuretic hormone. And the other causes of SIADH includes meningitis. Meningitis can also cause SIADH. Stroke cause SIADH. Hemorrhage can also cause SIADH. So basically you can say that if there are problem in the cerebrum or cerebellum, then SIADH will result. Remember this point because sometimes in Plab exam, they give you a scenario of SIADH and they ask you about which part of the brain is involved. So remember that if there is problem with cerebrum or cerebellum, it will lead to SIADH. Or if there is problem in the diencephalon, such as hypothalamus, thalamus, subthalamus, epithalamus, which are a part of diencephalon, then it will result in diabetes insipidus. So diencephalon for diabetes insipidus and cerebrum for SIADH. Don't forget this point. So SIADH, what is SIADH? In SIADH, there will be excessive secretion of antidiuretic hormone. And excessive antidiuretic hormone will lead excessive reabsorption of water from urine. Excessive reabsorption of water will lead to fluid overload and dilutional hyponatremia. So excessive reabsorption of water lead to fluid overload and dilutional hyponatremia. And what will happen to the urine? Because excessive water is reabsorbed from the urine, so the urine will be concentrated. The causes of SIDH is small cell lung cancer, meningitis, and stroke. SIDH will, what are the electrolyte abnormalities that are present in the SIADH? In SIADH, because of excessive reabsorption of water, sodium concentration will decrease, hyponatremia, and because sodium concentration is decreased, a decrease in the concentration of the sodium will stimulate the renin-angiotensin-aldosterone system, and the stimulation of this system will lead to hypokalemia. So hyponatremia due to dilution and hypokalemia due to increased aldosterone activity. Because there is hyponatremia, so serum osmolality will be low. And because excessive water is reabsorbed from the urine, so urine osmolality will be high. These points are important to remember because they will help you in differentiating SIADH from diabetes insipidus. So if someone present to you with low serum osmolality and high urine osmolality, then you will suspect SIADH. What is the treatment of or management of SIADH? Because there is excessive ADH secretion or there is excessive ADH production, so we are going to use ADH antagonists such as Viptans and demiclocycline. Both of them are ADH antagonists. The initial treatment or initial management of SIADH because of because there is excessive water reabsorption, so we'll restrict the fluids, and also as there is dilutional hyponatremia, so salt can also be given, and to remove excess water from the body, loop diuretics can also be tried. So stepwise management of SIADH is restriction of fluid, salt plus loop diuretics, and the definitive management is to oppose the action of ADH. We will give ADH antagonists such as colvaptan or demiclocycline. So in SIADH, there is excessive ADH secretion, and ADH is a water-loving hormone. So all the problems will arise due to excessive absorption of water. Low plasma osmolality due to high water in plasma, and high urine osmolality because of low water in urine. Now the other abnormality that is related with ADH is diabetes insipidus. In SIADH, there is excessive ADH secretion. In diabetes insipidus, there is low ADH secretion. Low ADH secretion or increased resistance to ADH. So diabetes insipidus is basically low production of ADH or resistance or increased resistance to ADH. So what will happen if there is low production of ADH? As I already told you, that is a water-loving hormone. So no water will be absorbed from the urine. As no water is absorbed from the urine, so urine osmolality will be high in diabetes insipidus. High urine osmolality or diluted urine will be produced in diabetes insipidus as opposite to SIADH. In SIADH, there was excessive absorption of water and concentrated urine was produced. And due to excessive water in the plasma osmolality was low. While in diabetes insipidus, as there is no water reabsorption due to low ADH, because water-loving hormone is not present, so there will be no water reabsorption from the urine, which will lead to a diluted urine, and the person will have polyuria and polydipsia because the water is not being retained in the body. And as water is not being retained in the body, so it will lead to increased plasma osmolality. Osmolality mean increased plasma osmolality mean increased concentration of salt or increased concentration of electrolytes in the body. There are two types of diabetes insipidus. One is cranial diabetes insipidus. Cranial diabetes insipidus mean low production of ADH due to problems in the diencephalon, such as a tumor of diencephalon. And the second type of diabetes insipidus is nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. In nephrogenic diabetes insipidus, ADH levels are normal, but kidney tubules are not responsive, or they do not show any response to ADH. There is problem in the ADH receptors in the kidney, because there is problem in the ADH receptors in the kidney. So that's why it is known as nephrogenic diabetes insipidus. So if someone present to you with polyuria or production of large amount of diluted urine and his plasma osmolality is high, then you will suspect diabetes insipidus. So if someone present to you with polyuria and polydipsia, then you will suspect diabetes insipidus. And the initial test that you need to perform for the diagnosis of diabetes insipidus is urine osmolality. So for Plab 1 exam, remember that if you're suspecting diabetes insipidus, the initial investigation will be urine osmolality. What will be urine osmolality in diabetes insipidus? High or low? Can someone answer this? Urine osmolality in diabetes insipidus, will it be high or low?
Will be high.
A
Urine
high
will be
urine a high osmolality mean high salt or less water. High osmolality mean more salt and less water, or more electrolytes and less water. But in diabetes insipidus, there is more water in urine. So osmolality will be low.
Oh.
In diabetes insipidus, osmolality of the urine will be low.
Okay.
Is that right?
Yes.
So the initial investigation, if we are suspecting diabetes insipidus, is urine osmolality, which will be low. Normal urine osmolality is between 700 to 850 milliosmol per kg. So if the urine osmolality is less than 700, then it is likely diabetes insipidus. Because in diabetes insipidus, urine osmolality is decreased because of excessive water in the urine. The next step will be fluid deprivation test. So initial test is urine osmolality, and the next one is fluid deprivation test. In normal people, what will happen if fluid is restricted? If fluid is restricted, normal people will produce excessive ADH and their urine will be concentrated. In normal people, fluid restriction will result in a concentrated urine because of production of ADH. Because when fluid is restricted, then the body try to conserve the water. While in patient with In patient with diabetes insipidus, even if the fluid is restricted, the urine osmolality is still high, low. The urine osmolality is still low even after fluid deprivation. So after fluid deprivation test, if the urine osmolality is still low, it does not increase, then it will confirm the diagnosis of diabetes insipidus. Now, the third test that we need to do to differentiate between cranial diabetes insipidus and nephrogenic diabetes insipidus is giving the person ADH analog such as vasopressin. So if after giving vasopressin, urine osmolality increases, then it is cranial diabetes insipidus. And if it's still decreased even after giving vasopressin, then it is nephrogenic diabetes insipidus. I'll repeat the investigation again. Listen carefully. Initial test is urine osmolality. Because there is excessive water in the urine, so urine osmolality will be low. Osmolality and water has an inverse relation. So high water in urine, urine osmolality will be low. The second test that we need to do is fluid deprivation test. If urine osmolality does not increase after fluid deprivation test, then it confirms the diagnosis of diabetes insipidus. Because normally the urine osmolality should increase after fluid deprivation, because there will be less water in urine after fluid restriction. But if it does not happen, then it confirms the diagnosis of diabetes insipidus. Now, a test to differentiate between cranial and nephrogenic diabetes insipidus is vasopressin test, in which vasopressin injection is given to the patient and his urine osmolality is measured. If after giving vasopressin, urine osmolality increases, then it is cranial diabetes insipidus, and if it does not increases, it remains the same or low, then it is nephrogenic diabetes insipidus. Is it clear to everyone? The initial investigation is urine osmolality or fluid deprivation test. Any of them can be the right answer. And the test to differentiate between cranial and nephrogenic diabetes insipidus is vasopressin test. Is it clear, everyone?
Yes, sir.
So this vasopressin is an analog of ADH.
Vasopressin is, you can say that the other name of ADH.
Okay.
They are one and the same thing. Just remember the basic abnormality. Excess ADH mean excess water in the body and less water in the urine. And low ADH means low water in the plasma. And as water and osmolality has an inverse relation, so low water in plasma mean high osmolality of plasma. So when there is low water in the plasma, there will be excess water in the urine. So high water in the urine means low osmolality of urine. So basically, remember 2 points to remember it for a long-term basis. One is that it is a water-loving hormone, and water has an inverse relation with osmolality. Just remember these two simple points, and you will never get a question of SIDH or diabetes insipidus get wrong. So this was all about abnormalities of the hormones that were related to the pituitary gland, prolactinoma, acromegaly, SIADH, and diabetes insipidus. Is it clear to everyone up to this point? If there is any question, then you people can ask. Otherwise, we'll start the next topic, which is Cushing syndrome or the abnormalities of adrenal glands. So, no questions. Okay. So, adrenal glands produce two hormones. Two important hormones are secreted by the adrenal cortex. There are two parts of adrenal gland. One is adrenal cortex, one is adrenal medulla. Adrenal cortex synthesize and secrete three hormones. One is cortisol, one is aldosterone, and the third one is adrenal androgens. And adrenal medulla secrete catecholamines such as epinephrine and norepinephrine. So we will discuss disorders of these hormones one by one. So the important hormones that are secreted by the adrenal cortex is cortisol and aldosterone. So if there is excess of cortisol or aldosterone, then this is known as Cushing syndrome. So Cushing syndrome is basically excess of adrenocortical hormones, which is cortisol and aldosterone. Remember that the most common cause of Cushing syndrome is exogenous intake of steroids. The most common cause of Cushing syndrome is exogenous intake of steroids. Some examples of the diseases in which patients are on a long-term steroid therapy or in which patient take exogenous steroids for a very long time is rheumatoid arthritis and asthmatic patients and COPD patients. So patient with long-term steroid therapy can develop Cushing syndrome, and it is the most common cause of Cushing syndrome. The less common causes of Cushing syndrome, the causes of Cushing syndrome can be divided into two categories. One category is ACTH dependent causes, and the other is ACTH independent causes. Remember that the release of adrenocortical hormone is controlled by the pituitary and the hypothalamus. From hypothalamus, SIADH hormone is released, corticotropic releasing hormone is released, which stimulates the pituitary gland to produce ACTH hormone. And then this ACTH hormone stimulates the adrenal glands to produce cortisol and aldosterone. So ACTH dependent causes mean in which the excessive production of cortisol or aldosterone is due to ACTH. And as ACTH is produced by the pituitary gland, so a pituitary adenoma secreting ACTH can lead to Cushing syndrome. But if pituitary is the cause of excess cortisol and aldosterone, then we'll call it as Cushing disease. So if the cause of excess cortisol and aldosterone is pituitary adenoma, then it is known as Cushing disease, otherwise Cushing syndrome. So the
Can you
most, yes, if the cause of excess cortisol is pituitary adenoma, then it is known as Cushing disease. We discussed before that the most common pituitary adenoma is prolactinoma. The second most common is non-functioning pituitary adenoma. The third common is growth hormone secreting pituitary adenoma. And the fourth common is ACTH secreting adenoma. So what will happen in ACTH secreting pituitary adenoma? The person will have feature of hypercortisolism and it will be known as Cushing disease. So ACTH dependent causes include pituitary adenoma and sometimes an ectopic ACTH production can also occur in diseases such as small cell lung cancer. So small cell lung cancer secrete two types of hormones. Both of them starts with the letter A. One is ADH, which results in syndrome of inappropriate ADH secretion or SIADH, and the other hormone that is secreted by the small cell lung cancer is ACTH, which can cause Cushing syndrome. So ACTH dependent causes is pituitary adenoma and small cell lung cancer, and ACTH independent causes are those causes in which its plasma ACTH level will be low. And the first cause of ACTH independent cause is steroids. Exogenous steroid intake will lead to a low level of ACTH due to feedback inhibition of ACTH from pituitary gland. Also, if there is adrenal adenoma or adrenal carcinoma or adrenal hyperplasia, means the cell in the adrenal gland start producing excessive cortisol. This excessive cortisol will result in the feedback suppression of the ACTH. So ACTH independent causes include steroids, adrenal adenoma, adrenal carcinoma, and adrenal hyperplasia. So Cushing syndrome can be caused by excessive ACTH, such as Cushing disease and ectopic ACTH production by small cell lung cancer, or it can be caused by an abnormality in the adrenal glands, such as adrenal adenoma, carcinoma, or due to excessive exogenous steroid intake. And the most common cause of Cushing syndrome is exogenous steroid intake. In the Plab 1 exam, the question, or in the clinical scenario, the question will be asked like this, that a person on a long-term steroid therapy develops the feature of Cushing syndrome. What are the feature of Cushing syndrome? The feature of Cushing syndrome include weight gain. Remember that, as I told you previously, that growth hormone cortisol, and glucagon. All of these are hormones. They causes gluconeogenesis and thus result in hyperglycemia. So what will happen if there is hyperglycemia? Remember that if there is hyperglycemia, then insulin will be secreted as well. And insulin secretion lead to fat deposition in adipocytes. So a patient with Cushing syndrome will have hyperglycemia, and due to hyperglycemia, there is increased production of insulin. So there will be weight gain and moon phase due to excessive fat deposition in cheeks, buffalo hump due to excessive fat deposition in the back area. So one function of cortisol is to cause hyperglycemia, and due to hyperglycemia, all these symptoms of Cushing syndrome occur, such as weight gain, moon phase, buffalo hump, and impaired glucose tolerance test. Now, the second function that you need to remember about cortisol is that it increases the sensitivity of epinephrine and norepinephrine receptors. And also, as in Cushing syndrome, aldosterone activity is also increased. So increased aldosterone, remember that the function of aldosterone is the function of ADH was to reabsorb water, and the function of aldosterone is basically a sodium loving hormone. So aldosterone causes a reabsorption of sodium because it is reabsorbing a positive ion. So in return to sodium, it gives out two positive ions. One is potassium and one is hydrogen. So it absorbs the sodium into the body. Aldosterone is a sodium loving hormone. It absorbs sodium into the body and excrete potassium and hydrogen ion in the urine. So whenever there is increased activity of aldosterone, what will happen? Increased reabsorption of sodium will occur, and increased reabsorption of sodium will lead to increased reabsorption of water and increased excretion of potassium and hydrogen ion. So the person will develop hypertension due to increased sodium and water reabsorption, and also he will develop hypokalemia because of excretion of potassium. And what will happen due to excretion of hydrogen ion? Hydrogen ion is basically an acid. So excessive acid secretion will result in alkalosis. So there will be hypokalemic metabolic alkalosis in Cushing syndrome. So if in the exam they ask you about the electrolyte abnormality or acid base abnormality in Cushing syndrome, then your answer will be hypokalemic metabolic alkalosis. Because in Cushing syndrome, aldosterone or mineralocorticoid activity is increased, due to which there is increased reabsorption of sodium and increased excretion of potassium and hydrogen ion. So if you remember these two functions, then you will never forget the signs and symptoms of Cushing syndrome. Hyperglycemia, which will stimulate insulin production, and insulin will result in weight gain and moon phase and buffalo hump, and increased sensitivity of catecholamine receptors, and increased mineralocorticoid activity will result in hypertension, hypokalemia, and metabolic alkalosis as well. Remember that increased insulin can cause acanthosis nigricans. So these were the feature of Cushing syndrome. Now investigation for the diagnosis of Cushing syndrome. We have already discussed that there will be hypokalemic metabolic alkalosis in Cushing syndrome and impaired glucose tolerance. Okay, there is one more other type of Cushing syndrome, and that is pseudo Cushing. So Cushing syndrome is caused by ACTH dependent causes, ACTH independent causes. Then there is another variant of Cushing syndrome. You cannot say variant, but a disease or a disorder that mimics the Cushing syndrome, and that is known as pseudo Cushing. Pseudo Cushing, the features of pseudo Cushing is just like Cushing syndrome, but the cause of pseudo Cushing is, remember, two important causes for pseudo Cushing, and that is either alcohol excess or severe depression. Alcohol excess or severe depression can lead to, or severe depression or alcohol excess basically stimulates the hypothalamus to produce CRH or corticotropin releasing hormone, which then stimulate ACTH, which then stimulate adrenal glands to produce excessive cortisol. So in pseudo Cushing, the dexamethasone test will be positive, and 24-hour urinary free cortisol test will also be positive. So in the exam, if they ask you about which test to differentiate between Cushing syndrome and pseudo Cushing, your answer will be insulin stress test. Insulin stress test is positive in pseudo Cushing, while it is negative in Cushing syndrome. Now, which test we perform to confirm the diagnosis of Cushing syndrome? The tests are divided into two categories. One is outpatient test and one is inpatient test. The initial test or screening test in outpatients is 24-hour urinary free cortisol, which will be raised. And the confirmatory test for the diagnosis of Cushing syndrome in outpatient is overnight dexamethasone suppression test or low dose dexamethasone suppression test. How this test is performed? Normally, administration of 1 milligram of dexamethasone. In normal people, if we give 1 milligram of dexamethasone, it will suppress the cortisol level.